I want to start by thanking you so much, Cheyenne and Felicity, for inviting me to be a part of the panel. And I'm honored, truthfully, to be part of this esteemed group of doctors and part of the whole community here also. When I put my slides together for the talk and I saw the group of panelists, I thought a little bit that it's a combination of the national Republican debate and the Winter Olympics, right? And then I realized, wait a second, the Germans were historically very strong in the Winter Olympics. I'm like, oh, but we're getting better. The Americans are getting better. Okay, anyway, on to this. So I'm Dr. David Amron. I'm the founder of the Roxbury Institute in Beverly Hills, California. It's the product of my vision years ago of creating something a little different and more special, combining both aesthetics with treating diseases. And this is finally the product of it. We opened a few months ago. Many of you have actually come to the Roxbury Institute. And it's really pretty amazing to me how nice the whole thing is working in terms of the treatment of the patient in a comprehensive fashion. And actually, lipedema and Derkham's such exciting things are going on, not only aesthetically, treating the disease and combining stem cell therapy. So no disclosure that I'm aware of. Anyway, I'm a board-certified dermatologic surgeon. I've been in practice for 21 years now. My practice has always been focused on liposuction surgery, and it has over the last many, many years been much more about complicated cases and a lot of revision work from around the world. I have been involved in lipedema surgery for 10 years, but for most of that time, I've got to admit, I really wasn't aware I was treating lipedema. I just would have all these calf and ankle patients and anterior thigh surgery, and now look back and realize that was lipedema. I've done over 600 lipedema surgeries. I do about 5 to 7 cases a week, rarely 8. Currently, my practice is almost exclusively dedicated to lipedema treatment and Derkham's disease. 2 things I believe in. Liposuction surgery for lipedema and Derkham's should be about not only the maximum functional improvement of the disease itself, but also the cosmetic improvements. Liposuction surgery for lipedema is truthfully very, very complex. It's not beginner liposuction, and there's so many different aspects to it in the total care of the patient, both from before surgery to the post-care of the patient, and just the technique itself is, as I think that we all know, is not straight-ahead liposuction. Anesthesia for liposuction, a very hot topic in the Facebook community. I know about this. I give my patients 2 options. First of all, I do believe it is a surgery, and I do believe ideally it should be done in an accredited surgical center. I have 2 options. Most of my patients take the option of doing it where they're quite conscious, and I basically am acting as the anesthesiologist, putting that fluid in, called the tumescent fluid. I give sublingual Valium prior to the surgery to take the edge off of things, and then I decide in the OR itself if I'm going to give a little bit of fentanyl intravenously or IV Versed, and then I've begun to use nitrous oxide too, the way the dentists used to or still do to help the patient. And about 10 to 15% of the patients I do with an anesthesiologist there under a so-called twilight. This is really an article that I have referred to many times over the years talking about safety with liposuction. And it's actually quite a ways back now. It's the year 2000. It's a large study in almost 500,000 patients, and it shows a 1 in about 5,000 mortality rate with liposuction under general anesthesia for a number of reasons. And it really is one of the main reasons I strongly prefer avoiding general anesthesia with liposuction surgery. And so there are 3 reasons why I prefer to avoid general anesthesia. Number 1 is safety, like we just saw. Number 2 is it's definitely a faster recovery for the patient, not only just the nauseating effects of general anesthesia, but the patients are walking right after surgery also. It also creates essentially a bloodless feel by putting in the tumescent fluid first. But really the main reason which I've starred over here is about results. Liposuction is a very different type of surgery. It's not a cutting and sewing surgery. It is a very precise contouring and sculpting procedure in every patient, and the ability to position the patient, to me, is crucial to be able to get the best functional and aesthetic improvements. I developed a circumferential, sort of 3-dimensional approach to treating cosmetic units that we'll talk about during each surgery. And this is not only with lipedema patients, but I developed this with just aesthetic patients years ago. So when I do the torso, when I do the calves and ankles, I prefer to approach it in a complete fashion, circumferentially all the way around. These are some of photographs of markings for calf and ankle liposuction. And a big part of this is oh my God, where the incision placements the incision points are made to be able to get around those areas precisely. Boom, boom. Thigh surgery all the way around, again, some more markings. I'm grouping cosmetic units. I've talked about this before. I group them in a certain way. This is important stuff, though. Calf and ankle, we got an hour and a half. Calf and ankle surgery usually is grouped with arms. People ask that a lot. That's the way I tend to go about a treatment plan. The second thing I approach is the circumferential thighs as a cosmetic unit, sometimes with the buttocks. And then lastly, if I'm doing the torso, whether there or not be lipedema there or not, that's the way I approach it. I use wall-to mesh. This is the way I use the wall. In every single patient. I use it as a way of putting the fluid into the tissue. I use power-assisted lipo for decongestion. This is extremely important, I find. Tools to me aren't as important as other things, but it does do a very nice job of decongesting the tissue. One of the most important decongestive things you can do, I think, is liposuction if it's done properly. And for debulking, I use a laser quite a bit in half the patients to thermally emulsify the tissue if there's a lot of fibrosis, especially with Derkham's disease too. I go back with a pal for further refining superficially, and then I will sometimes use a laser for further additional skin tightening. Some before and afters, you can see this on different sites of mine. Most important factors to ensure the optimal result are these things. At the end, I'm just going to mention that certainly with lipedema, heart's a very important thing in the caring for the patient. The team approach is very important. The medical doctor, endocrinologist, ideally Dr. Karen Herbst, can I butter the moderator up? MLD therapist and lymphologist. I use Dr. Emily Eicher a lot, an MLD therapist in the area. Surgical team is, of course, very important in terms of the tech, the RN, the anesthesiologist sometimes, and of course, plastic surgeons if they're needed for body tucking procedures. And lastly, I just want to say that I think we all have a responsibility to increase awareness about lipedema. I'm not quite as smart as Karen Herbst, but this is what I use as my tool to battle the ignorance that goes on with lipedema. A lot of the media, and I'm dedicated to continuing this. Thank you.
We'll all be faster, which may be surprising because typically plastic surgeons love to talk about themselves. So usually I could go on for hours upon hours. But I'll try to be brief. I mean, I echo what Dr. Amron mentioned and what probably the majority of the other folks up here will mention, that it's really exciting to be here. Thanks to Cheyenne and Felicity for the opportunity, to the entire FDRS group. I mean, it's pretty amazing that a few years ago, the group started as 5 people, and then you look around in the room and you see 263 people sitting here today. So maybe a quick round of applause to everybody for that. I don't have any disclosures. I see a lot of familiar faces here, but in case many of you don't know me, you may be wondering who is this guy. Well, my name's Donnie Buck. I'm a plastic surgeon here in St. Louis. I work at the WashU School of Medicine. I'm the associate program director there as well. I was actually born in southern Indiana, a real small town of about 14,000 people. I have a family of 6, so I have 3 siblings. I'm the first physician in the family, so that created a lot of interesting holiday dinners when I was going through medical school. And then from there, I went to Indiana University for my undergraduate degree. I played football there, surprising to many people that Indiana actually had a football team. We actually participate in the Big Ten, and participate is really the key functioning word there. From Indiana, I went to Johns Hopkins for medical school. That's where I sort of fell in love with plastic surgery. I originally thought I was going to be an orthopedic surgeon, and then I experienced all of the creativity in plastic surgery and changed my mind. So I matched into the program at Northwestern. I spent 7 years at Northwestern in training, completed a reconstructive microsurgery fellowship at the University of Toronto, where we did all sorts of microsurgery, including breast, head and neck, extremity, and some lymphatic work. And then I was recruited here to St. Louis. My wife was ecstatic about that. She grew up here in St. Louis, so I came back here and joined the Department of Surgery at WashU. Really, the focus was to build a plastic surgery division at one of the community hospitals where we were expanding to, but also develop a center of excellence in reconstructive microsurgery, lymphatic microsurgery, and then by happenstance, really, treatment of rare adipose disorders. So that's why I'm kind of standing here today. As I mentioned, I'm the Associate Program Director of the Residency Training Program. So we have 18 residents and 2 fellows. So at least each year I'm sending 2 other people out into the world who are aware of this disorder and aware of the treatments available to patients. WashU, a little bit about that. It's annually ranked as one of the top 10 institutions in the U.S. since the rankings began in 1987. It's also listed as one of the top training programs in nearly every specialty. There's greater than $500 million worth of annual research funding at the school. From an academic achievement standpoint, I'm certified by the American Board of Plastic Surgery, the only board recognized by the American Board of Medical Specialties in plastic, reconstructive, and aesthetic surgery. A member of several societies. I've authored over 150 articles, textbook chapters, abstracts, and presentations in plastic surgery, and I've actually edited 2 textbooks. You can see here, and I'm an editorial board member for several different journals in plastic surgery. How I came into lipedema is really through my lymphedema clinic. So when I came here to St. Louis, I developed a very busy lymphedema clinic, and I would see a lot of patients who had this characteristic swelling that spared the feet and hands, and through kind of further knowledge and reading myself, discovered that this was something different. So it wasn't that I came in knowing all there was to know about it, and similar to Dr. Amron, probably through training, we did a lot of cosmetic liposuction on early stage 1, early stage 2 lipedema patients, and didn't realize that that's what that was. So as a result of that, I sort of developed my own approach to it by combining what I had known or what I had learned in cosmetic liposuction and lymphatic microsurgery with a lot of the techniques that I had read about with Dr. Rapprich and Dr. Stutz. And through that, I've kind of developed my own unique approach to this. I think that from a simplistic manner, similar to the other folks up here, I think really patient first is kind of my approach, really safety first, and that's why I do it in a staged fashion. We'll talk probably a little more about details, I would imagine, along the way. I think our office is set up. I have a really hard-working office. My administrative assistant is phenomenal. She knows all the ins and outs of billing and insurance, and so we really work hard in our office to kind of leave no stone unturned from an insurance coverage perspective. Me, as a person and a surgeon, I feel bad that you should be held financially responsible for treating a disease that you didn't ask to have. So we, yeah, thanks. So we work really hard for that. Unfortunately, we're not always successful. I would say right now we're probably at about 65%, but it's better than a year ago where we were about 40%. And so I think it's an example of this increased awareness that people are starting to listen. So we just have to keep pushing forward. I'll advance here. I have a couple before and after pictures. I don't know why this isn't. Oh, here's our team, a team approach. This is the group you'll see at our center. So the upper left is the pre-op folks that are going to welcome you in, ask how you're doing, calm you down before we go back. The lower left there is my lovely OR nurse, Kayla. She's going to be your angel in the operating room. And then the upper right are the PACU nurses who you'll see when you come out into recovery. The team on the lower right, the one on the far right is Amy, that's my office assistant. The one next to me is Allie, she's our medical assistant, and Katie is also there, my nurse practitioner who's in the room. Give a big wave, Katie. Yep, there's Katie. So before and afters are probably similar to most. There's a significant improvement from a contour perspective, there's no question, but I think the big things that I like to focus on are the fact that people are running again, they're driving again, they don't have any more pain. And we can go through pictures all day, but really the operative results I like are the operative results of people wearing boots, saying that they no longer need a cane to walk, that they can sleep through the night and raise their legs above their head so if they choose to do it. And there's no question that the aesthetic improvements are important, but I think they're secondary, and I think this is one of the key aspects in terms of fighting insurance for getting coverage, or that if we make it about the aesthetics, we're going to have no chance, but if we make it about the functional aspects, there's a shot. So. With that, we're here to help you. Thank you very much. Okay.
My name is Dr. Marcia Bird, and I have the Lipedema Liposuction Center and Bird Aesthetic and Anti-Aging Center in Roswell, Georgia. They added this one. I guess I don't. I don't. I was trained at the University of South Alabama. I stayed there for residency in OBGYN. I was introduced to liposuction about 20 years ago at a medical meeting, and I was so excited I couldn't wait to get home and find somebody to teach me how to do this. Over the next 2 years, I went to the United States and Europe and found several doctors to help me learn how to get this accomplished. And for the past 18 years, I have been working on my patients. For the first 2 years, I worked on all my family. Now they hide from me, you know. I was also very fortunate to meet Dr. Stutz, and I worked with him. I went to his office for a few days, and he came to my office and worked also here in Georgia. Liposuction represents about 80% of my daily activities. With 18 years experience with liposuction techniques, I've had the opportunity to use many techniques. I like water-assisted liposuction and power-assisted liposuction the best. They work the best in my hands. We've also go back in our office and looked at photographs from years ago, and we've noticed that we were treating lipedema well before I knew what it was. And I think the patients have done well just because of the fact that we have been using PAL and WAL for so many years. Societies include liposuction surgery, cosmetic surgery, and anti-aging medicine. The photographs, the first one is of a lady, and it shows before and a year and a half after surgery. You'll notice the improvement in her knees. Her main symptom was the pain and the difficulty walking. The next lady is a stage 3 patient. She had no pain, but she complained of difficulty with walking and heavy legs, and you can see they were pretty heavy. After treatment on that lady, her walking ability has greatly improved, and she's very, very happy, even though the cosmetic aspect is not that great. This lady came in, she's really interesting. She came in complaining that her feet throbbed all the time. And her legs, of course, ached, and she was having some pain there. We started with the left lower leg from the knee to the ankle. When I finished that, I went to the right side. Just a few minutes later, she stopped me, and she said, the throbbing stopped. We went to the other leg, finished that, and when it was completed, she said that pain stopped too, and it's never come back. This lady came in complaining of the usual heaviness and the pain. The post photograph is about a year out, and she's been doing well. This is real interesting. This lady, can you see that? Well, she sent this to me from her home. She made a photograph of her ankle before surgery, and then about a year after surgery, and you see the difference there. This lady came back for her second operation, and you look at her saddlebags where they're marked in her thighs. But note the difference between the calf and the decreased ankle cuff. It's very impressive. And this is my best one. And this lady just sent me this a couple of days ago. She ran a race in January of 2015. She said she ran 5K. She had to stop and start the whole way. The second one, the after photograph, is January of 2016. We did surgery a month after the first one. She was able to do 15 Ks and not stop. She ran the whole race. She had lost 60 pounds. To me, that's an ideal outcome. It's more about the quality of your life. Okay, thank you.
My name is Stefan Rapprich. I joined the conference in 2011 already in Chicago, and it was I enjoyed it really. And I saw what a great organization you have, and I brought some ideas to Germany, to our lipedema groups there, and you can imagine they have the same problems than you have here, and it was a good improvement for us. Now, I do liposuction for 25 years now. I started at the dermatologic clinic in Darmstadt. My assistant professor at this time brought the technique from the States, the tumescent technique. He wants to make just cosmetic liposuction, but other colleagues sent lipedema patients to us in order to do a liposuction, and we didn't know. We had the opponents of lymphologists. They said, oh no, don't do any surgery, you damage the lymph vessels, don't do that. But we have been encouraged by patients, and we saw that by our cosmetic liposuction, we didn't damage any lymph vessels, so we started and we saw it works. Well, then I work at the clinic as an assistant professor for 15 years, was responsible for the dermatologic surgery. I also do phlebologic surgery and even the liposurgery. And since 1 year, I work in my own office. It's in Bad Soden, near Frankfurt. And we have a big team here. Bad Soden, it doesn't, in Germany that means it's not bad. Bad, the name Bad is in the city with healthy environment. And that's really, it's near the Taunus Here's Frankfurt and here's the airport. And this is a part of the clinic. We have here operation theaters and bedrooms for patients to stay overnight. And I also work in 2 other places in Germany. One is in Landstuhl near Kaiserslautern. Many Americans live here because there's the biggest air base out of the States there. And in the Rosenberg Clinic in the southern of Germany. Well, I use a power-assisted liposuction. Well, I grown up with this technique, but I also worked with a water jet assisted. Well, I know both techniques, and I can compare maybe later in the discussions, and treated 600 patients so far, more than 2,000 procedures. And 10 years ago, we started to evaluate our results, and this leads to 2 studies published the last years. And in Germany, we have guidelines. I'm a member of the guideline group, and we just made an update October last year. It will be published soon in English also, I think in June, and I think I will provide it for this community. Now some picture how I do the liposuction. The first step is the plan. The second is infiltration of the tumescent solution. We have a saline solution here, and I use 6 to 9 liters, sometimes also less, by infiltration pump. And the skin will be anesthetized before. It's completely under local anesthesia, and with several syringes, it will be, in a way, pumped up so that the skin is really tight and completely anesthetic, so that I can use a liposuction without pain. You see here the cannula, the vibrating power-assisted device, and I can treat the patient in different positions, which is very important for me to do this under local, and otherwise under general you haven't this possibility. And also difficult areas around the ankles are possible to treat with this technique without damaging any lymph vessels. The arms are possible to treat also in the same way. And the advantage of local anesthesia is also to check in a standing position. Sometimes there is a correction necessary, and it's just finished when everything is fine. Also the contour and the shape. Well, the incisions are covered with bandages, and very important is also the post-operative compression garment. In this case, also with additional bandages. And the aspirate, it depends on the case and the area. This was just out of the lower legs from the lady. The aspirate is, in my cases, from 1 to up to 5 liters. Regularly, I do the follow-up, and in this case, even no bruising, no hematoma. When I want to treat the whole leg, I don't do it in one procedure. I do it in 3. So inside, outside, and lower leg. My postoperative protocol is with antibiotic prophylaxis, heparin prophylaxis, compression, very important, 2 times for 6 weeks or longer, and MLD, as long as there is a swelling. Our study showed that it's a pain therapy. It's from the scale from 8 almost to 0. And here are some examples. This is my showcase in a way. The ideal patient, normal weight, stage 1, young, sporty. Here we have the best results. In elderly patients and larger cases, it's more difficult. Even in slack skin, we have here here may be a skin retraction necessary, but this is cosmetic, that's clear. Or here this patient was able to wear boots again. Also, lipolymphedema is possible to treat, but these patients need after continuous conservative therapy. In stage 1 or 2, we have the chance that they don't need this anymore. And another effect is seen in this patient. She has been more active, new life partner, new life quality, and reduced weight in her other upper body. That's in the self-running process. Well, what about the long-term results? These are results from Wilfried Schmeller. After 6 months, reduction of pain, and after 6 years, we have this follow-up period. It increases slightly, and that is also my observation. My data are in press. And finally, lipedema needs a whole therapy, and my model is to base it on 6 columns. We heard a lot about nutrition, sport. Liposuction is just one column. Compression is important. The MLD is very important, and the psychological aspects we heard also. Now, one word about the sport. I recommend aquacycling. Why? The joints are decompressed, the body weight swims. You have an MLD effect by the water pressure. You have a massage effect, which is a benefit after lipo. And you have a volume shift of your blood from lower to upper body, which puts out a hormone to burn calories 3 times more effective than by jogging. Our current studies are ongoing and waiting for the analysis. Thank you very much.
Hello, again. So, make it short. I live in Bavaria, Germany, just on the border to Saxonia and Thuringia. The closest and well-known place is Bayreuth, where the Wagner Festival happens to be each year, and that's a famous place for this. So I came from vascular surgery, and as many of my other colleagues, we didn't have an answer for people with heavy legs pain, and we didn't find any problems with veins, arteries, or lymph vessels. So we had to dig into the literature and found a disease which was called lipedema, and it was fairly new 20 years ago, and we started with the liposuction, and as Stefan already mentioned, we had to overcome a lot of obstacles. People were really, they tried to convince us that it's not the right technique to improve the life for these people. After 10 years, we were in a stage where we could convince the physiotherapists and the lymphologists in Germany, which is quite a severe group. We do have lymphologists, we have lymph clinics, so we could convince them that this kind of treatment is beneficial for the patient, if done in the right way. So I'm just doing liposuction, nothing else. I just treat lipedema and lymphedema, no cosmetic procedures. It's just a question to be not being, for the insurance companies, suspicious doing some cosmetic procedures. So we just treat exclusively this kind of patient. Because it goes along with, often with phlebology, with vein diseases, so I treat vein diseases as well, which was my start with. So I do wall procedure, which is a water-assisted liposuction, which does not need the fluid you take in many liters. It's just, it's high pressure. You rinse the fat out and more than you suck it out. So because it's done under local anesthesia to 100%. People has to walk immediately after the procedure. Even people coming with a wheelchair to my office, I chased them away and said, you have to go, and they have to walk a lot immediately after the procedure. This prevents deep vein thrombosis. This prevents no infection, so people start walking immediately after the procedure. So not really trauma, and it's compared to the big size of the operation. It's cut down to a rather small procedure. It takes a long time, but people are mobile immediately after the procedure. And as I said, they start walking immediately after the procedure. One of my specialty, I don't have any weight limits, so many people with very, very late stages, you probably would call it stage 5, 200 kilograms and more, came to my office, and because it's a pure local anesthesia, and we don't need a lot of fluid, so we just put in 1 liter to start with the liposuction. So even comorbidities, having a weak heart or having diabetes, it's not an obstacle, does not hinder the liposuction. This, I published a few things which are important. So I, like other colleagues, I tried to get awareness within my group of colleagues, and I had the chance to train about 30 colleagues in Europe and in the United States as well. So we have established another crystal point. From there will be other colleagues trained, and the procedure of liposuction will spread in the United States over the years as well. So you have a greater variety of colleagues who treat this disease. So, yeah, I guess that's it. Thanks for your attention.
So those are great presentations. Thank you very much. And I'm just going to ask some questions specifically of each one of you, but the other ones are welcome to comment. And I'd like to just start off of a comment that you made, Dr. Stutz, is that you'll take any size woman, even stage 5, lipedema, whatever that is. David, you just want to start and tell me what kind of patients would you not take, and what are some contraindications which would make you not conduct the surgery?
Well, similar to Dr. Stutz, there's no real specific age limit or weight limit. I mean, patients age 14 or 15 to the 80s, as long as they're medically quite stable. But again, doing it under local anesthesia is quite safe. Again, no real weight limit that I have. Okay. Contraindications, I think that every patient has to be taken individually in terms of going ahead with the procedure. It's very rare, quite honestly, I ever completely reject a patient, and I think that we have to take that very, very seriously, because we are the end, of the choice.
I think you took the safety of one of my patients into account, and she had a lot of swelling that she didn't have under control, and you decided to postpone her. She was just really swollen. Right.
So I can go on and on. So first of all, when I try to involve people like yourself or other medical doctors in the care of more complicated, high-risk patients, I think it's an important thing to do, or hematologists, whatever it may be. I think that you start dealing with patients who are later stage 3, stage 4, especially lipedema, which is to me something that you take very, very seriously. They're very heavy, large patients with that woody fibrotic change to their lower legs, and how you approach that patient. I think we all, it's an interesting thing. I think we've all kind of come to a very similar way of approaching things from different directions and learn from the patients. But I think that to a patient takes a lot of thought in terms of how to approach. And I'm kind of curious to hear that. I mean, I've learned that decompressing from the top up, down in those patients is important to release.
Okay, we'll talk about that.
But also pre and post care too, how important the care is pre and post in those are complicated patients.
Okay, Marcia, any size limit, any contraindications?
I think if they're in good health and they've done other things before the surgery, MLD, they've eaten healthy for several months, I think they're optimal candidates.
Great, Dr. Buck?
Yeah, I would just echo the same things. I don't think I have a cutoff per se. I sort of see all patients, all stages. I do think it's important, maybe echoing what my German colleagues mentioned, that it's really, my approach is more of kind of a multidisciplinary, treat the patient as a whole type of approach. So if I see many of you, and some of you I have seen in my office, and we've talked a lot, Dr. Stutz and I talked about lipedema being potentially considered a cause of obesity because of the cycle of frustration, not being able to lose weight in your legs, ridicule at a young age, eating disorders, and then the immobility, so that your your net calorie bucket is always positive and you can't lose weight, and it's just a vicious cycle that goes on. I often have a conversation with a lot of my patients who may have morbid obesity coexisting with lipedema, that maybe the best bet for them from a health perspective is to really get them on some form of nutrition, whether it's with a nutritionist, whether it's to discuss bariatric surgery to treat them as a whole, and then focus on the lipedema afterwards. So there are times when I might delay my approach to them, but I never outright reject them. It's more of treating the individual as a whole, and what can I do best for them to make them best and optimize their results. So.
Do you have anything you want to add, Dr. Raprich, or you?
Yeah, for me also no weight limit. If otherwise healthy patient with no risk factors for surgical procedures. But I tell the patient that the result will be better the more weight they lose before the surgery. If there is an additional obesity, then it should be treated by all the things how obesity can be treated, but actually no weight limit. I wouldn't reject a patient if he wasn't able to lose any kilogram.
So Dr. Amron mentioned that when you decongest the tissue using liposuction, that they can have some improved weight loss. You mentioned that it might be a good idea to lose weight before surgery. Dr. Stutz, do you have any opinion on bariatric surgery or liposuction first?
Not really. So I prefer liposuction first. We all know how desperate these people tried to reduce the weight. They had so many frustration over all these years, and they always got the same advice: lose weight, move, do more exercises. So, and what advice? Unless you take them to bariatric surgery, you can't give them another advice, just lose weight. So there's another year lost, and then they come back with 3 kilograms less than they had before. So I can't see the reason for it. So I just start with the liposuction, make them more mobile, and many of them lose right away after the procedure a lot of weight. So and there's no additional bariatric surgery necessary afterwards.
Dr. Bird, do you want to comment, and then I'll come to you.
I'll just echo what Dr. Stutz says and say that, the weight doesn't really matter, but I think that it's better to do it first and then try to lose the weight if you need to, as long as you're eating healthy before the surgery.
David, you'd agree?
I think that bariatric surgery really is the wrong recommendation and choice for patients initially, especially with lipedema, because you're dealing with this disproportion, this immense disproportion. And I think that some of you saw I was in this doctor's show with a patient who had bariatric surgery first. And what happens, they end up losing a lot of truncal fat and visceral fat. And in a certain way, it kind of makes the lipedema kind of more disproportionate, because the fat are stupid storage units, they'll store wherever they are. So, I really think that, I agree with Dr. Stutz, you really liposuction first, then consider the weight loss later. And then the fat acts like a huge hormonal organ in a way, and by losing all that fat with liposuction, the patient sheds weight afterwards.
So, Dr. Buck, you mentioned quite a few, how you personalize treatment for your patients, and you talk about nutrition and other things. What are the 3 things that you want your patients to do before they come see you, 3 plus or minus 1?
Yeah, so I think one, just in general terms, some form of a diet. So if they need assistance, we have nutritionists here in St. Louis that we work with, and we'll send people to. Otherwise, I often direct them to your site, which has a lot of great information from a nutritional perspective. The other is some form of activity, so I want them on some consistent activity, even if it's putting the laundry detergent on the other end of the house so that when they do laundry, they're going back and forth, some form of consistent activity. And then the other thing, which I think is really critical for the ease of fat removal, is to use the conservative treatments like MLD, FlexiTouch, or home pneumatic compression, and compression garments, because it'll get rid of some of that fibrosis, so the fat comes out a lot easier. It's a more gentle procedure. There's less trauma, and it's just an overall more successful surgery.
Great. Dr. Rappridge, do you agree, or do you have other ideas? Would those three things be on the top of your list as well?
Yes, I would agree.
Okay.
100%.
Dr. Stutz, would you agree?
Yeah, exercises, some people came with a wheelchair, so you can't ask them for exercises, so they can move their arms, they hardly can comb their hair. So what kind of exercises I am really recommend? So we try to decongest, which is important, of course, but the other activities prior to the operation are really limited, at least in plenty of my patients.
Dr. Bird?
Yeah, I really like total body vibration. I think it's an easy thing to do. It feels good. You can do it for a short amount of time, which I love. 10 minutes is equal to an hour of lifting weights, so why not? Swimming's also good.
Anything to add, David? Are those your top three?
I don't know, top three. I mean, I can't disagree with things that were said. I think nutrition is, of course, important. Like I think Donald said, I basically refer them to your site. I think the one thing I would say, though, is that in the pre-care of the patient, how you determine which patients need what is very, very important. I think again, like I said, you're dealing with a very advanced patient. Pre-compression therapy and something that becomes, essential. Quite honestly, I think stage 1, stage 2, to me, and I've had eyebrows raised at this, it's not a vital thing to do in those patients in terms of really changing the process of the surgery. And the surgery itself is going to make the biggest improvement. But then, of course, the post-care becomes important in terms of compression afterwards. So the pre-compression therapy, I think, for MLD is not always essential in every single patient.
Mm-hmm. So I make recommendations for lots of supplements and medications, and they come to you on 15 different things. What do you continue, or what do you make sure they stop before they have surgery? Marcia, any thoughts on that?
I usually have them stop pretty much everything at least 10 days to 2 weeks before, and it depends afterwards. I tend to let them start back. I used to say 2 weeks afterwards, but I tend to let them start back sooner after surgery. You just want the lidocaine to be gone.
Donnie? Anything?
For me, I don't necessarily recommend anything except for maybe something that is known to have an effect on prolonged bleeding. But realistically, there are very few of the supplements that you're recommending that have that effect. So the main thing is not taking any non-steroidals, which is your presentation earlier said they shouldn't be taking them anyway. But if they're on something like that, then I usually have them stop a week or 10 days before.
Stefan?
Well, I must say, in Germany, the supplements are not as common.
Okay.
So, of course, medicaments which affect bleeding, they should be stopped 2 weeks before, that's clear. Concerning our medicament we give for the anesthesia is prilocaine. We give in addition vitamin C for better metabolism. Before and after, we recommend.
Okay, so prilocaine?
Prilocaine, the metabolism, it causes a methemoglobinemia, but it's under control and the reduction is supported by vitamin C.
And how much vitamin C do you give?
1,000 per day.
1,000 per day.
Yeah.
Okay. David?
I basically agree with Marcia. I stop mostly everything that you start them on, except things like Adderall and thyroid medications. I mean, with all the supplements, and there's a lot of different supplements, we don't know exactly. I mean, some of them have effects on bleeding, but not all of them. But then it confuses the patient, too. It's just easier to say just stop those. I don't think it's stopping them for a couple weeks is going to make a difference. I usually start, again, 2 days after. A lot of them also we got to think about when we're using a lot of high levels of lidocaine, and we do, quite honestly, up to 55 milligrams per kilogram body weight. I don't want anything else competing with the P450 system of the liver in terms of detoxification. So, I like a little bit of a cleaner approach and not having a lot of medications on board.
Did I miss anyone? Nope. Okay.
The only thing we have to stop is aspirin.
Oh, aspirin.
That's really important. Nothing else really matters. So, but aspirin is just could be lethal.
So Dr. Buck was talking about treating the whole patient. What about the emotional aspect of the patient, which I think is very complex because there are a lot of different levels of expectations of what they're going to look like after surgery and how they're going to feel. So how do you deal with those emotional issues? And that's a big question, so who wants to start?
I'll jump on that one, I guess. So, it's a tough question. I think it's a little bit individualized. I mean, I think the easiest approach is just communication. So we spend a lot of time talking in the visit, over hours. Katie, my nurse practitioner, is involved. Amy, my assistant, is involved. We communicate regularly. I think that, expectations are really important. I think it's a huge important factor with regard to outcome. I do know that, after this surgery, from a functional standpoint, you're going to be a lot better. The question, though, that often comes up for many patients is, what am I going to look like? There are a lot of people that focus on the before and after photographs, and the aesthetic improvements are certainly there, and they're important, but they're secondary. But I recognize they're important. So we talk through them. We look at photographs in the office if patients are interested in looking at photographs of, what does this typical stage 3 look like after, or something like that. Not everybody's that interested in looking at photographs, but we have that as an option. And I think that, in worst case scenario, when you have patients who are depressed and have some of the mental health issues that Dr. Stutz alluded to earlier with his presentation, then, I have no problems talking with them and trying to get them help through referrals to, either psychiatrists or psychologists, or somebody who can help them through that situation. But listening and talking to them are step one, and going from there after.
Great. And I think, Dr. Stutz, we know you take your patients and you talk and listen to them. Is there anything else you do for their emotional self?
I guess for many of the patients, it's the first time they came to a doctor, they understood this disease. And this is such a relief. And I guess so they feel they have been understood. So that's the most supportive message I can give them.
Great. Stefan, anything?
Well, I would completely agree, as Joseph Stutz, that many patients have eating disorders or depression, and they are already under therapy. So there is, for me, no need to involve in a way. And often by therapy of the lipedema, it recovers itself, especially the depression and the eating disorders. And by the 20 years experience, I observed another interesting thing. Imagine what that means, that the body of a lipedema patient changes in a very short period. We do the free liposuctions in a period of 3 months. That's a very dramatic change in a positive meaning for the patient. But it's faster than the brain can follow for
Yes.
some.
Yes.
And that should not be underestimated. Let the brain follow the body change. Yeah.
So emotional support after liposuction is
yes.
very important.
Yes. Well, it's not no professional need for, but we should be aware of this phenomenon.
Interesting. Marcia?
There's a natural hormone release when you're doing liposuction, and it's quite common to see somebody experience short-term depression that occurs in the first couple of weeks after liposuction. So for the most part, most people that have this, you can just talk to them about it, and it gets better. I've had people call me and be in the middle of the grocery store and just start bawling and say, what's wrong, what's wrong? If you just talk to them, oh, okay, it's going to be fine. And that usually works.
David?
Well, lipedema is a very emotional condition, and I see that most of the patients see me one way or another, either in the consult or afterwards they start crying. So it's definitely, when you put yourself out there as a lipedema surgeon, you're taking on a lot in terms of many aspects of caring for the patient. That's why I really kind of want to see a slow adoption of people starting to become lipedema surgeons, because you have to truly be committed to it. I do believe what I said, that I do feel responsibility for both the functional treatment of disease and the aesthetic component of it too, because you're trying to meet patients' expectations and make them as happy as possible in every single aspect, their symptoms and also how they look too. But just one word I just got to say, Dr. Stutz and I were talking outside about meeting the needs of patients, and there's a lot of communication, certainly in the Facebook groups, about things, and all comparing to other patients, and each patient is different with lipedema. You are all unique patients, and there's certain similarities, but to us as surgeons, it's all within the realm of what is normal in terms of what you go through and recovery and results too. And to understand, I think we all feel the immense responsibility to treat your disease and to make you feel as good as possible too, but it's also a multifactorial thing going on. Every patient is different, and it's not only just about the removal of the fat. I think we feel as surgeons here, we play such a vital role, but it's a team approach, and the stem cells possibly migrating out of the leaky lymphatics and turning into, you understand it's a very complicated process in all patients, and a big part of it is the swelling lymphatics. It's not always going to go in every patient with a liposuction. So, that's just part of the whole relationship, doctor-patient relationship, that I think all of us as physicians feel, and surgeons, that we're part of this improvement as a doctor and a patient, and that there's norms.
So one of the things that we as a community don't completely understand, which I think feeds into that emotionality of the experience, is, does the lipedema fat tissue come back? And we saw Dr. Rapprich showed us some data that, pain comes back a little bit more at 6 years. So I'm going to just hand it off to you, Stefan. Does lipedema fat tissue come back after liposuction?
Well, in 50%, none. In 2% of the patients, it's after 6 years the same than before. And in 18%, it comes medium, and 20% slightly after 6 years. This is what we evaluated by our long-term observations. By liposuction, we can't remove all bad fat cells. There are still lipedema cells in the patient after, and they will behave like lipedema cells. Well, this is my hypothesis. And they will behave like lipedema cells and will grow and will cause this slight progress over years. We cannot heal because the pathogenetic is genetic. We need a gene therapy for the causal therapy, which we don't have. So nowadays we just can reduce the number of bad fat cells. And
does anyone else have experience with lipedema fat tissue coming back?
Yeah, there is a group of patients where they are really endangered that lipid comes back, which are the anorexic people. They continue starving after the procedure. It's really a mental problem, which it's difficult to break through, that they just start eating normal. And these people, they have a higher tendency that the lipedema fat grows back when they are continuous starving. And there is another group which I think it's important. Some psychological problems, having a big operation or having a loss in a family or some car accident. So I think there is a tendency that lipedema fat, I'm not sure if it's really lipedema fat, so they don't complain about the same amount of pain they had before, but there is a tendency. On the other hand, we followed up young ladies who had 2 or 3 kids after the liposuction, and nothing came back, really nothing. And they didn't even wear compression stockings during their pregnancy. As a phlebologist, I would really highly recommend this. But they say, I'm so happy with my legs, I don't feel any pain, I have no swelling. I'm not wearing these compression stockings anymore. So we see it's obviously there are some tendencies, but we are really not sure why it restarts. But it's really a minority. It's a small group.
I'd like to ask everybody something. Patients ask me often, why do my breasts increase after liposuction? Or why does it move to some other place? And I don't have a good answer yet.
I do.
Good.
Well, the team approach. I mean, I kind of view the fat as stupid storage units. So, you know, liposuction, lipedema or not, just in any patient, is really more of a rebalancing, reproportioning procedure. So, you know, and that's why I think that you have to evaluate each person individually, even non-lipedema, because you're shifting a person's thing. So you're targeting disproportion with liposuction. And that same thing we're doing with lipedema. So when removing all that disproportionate fat, there is a tendency to have some lipo shifting going on and store more in remaining fat tissue.
It seems like there's a thermostat. Your brain or your body somehow tells you have to have this much fat, and if you remove more than you should, then it's going to have to go somewhere else.
There is a U.S. study years ago that was out about that, and they used that to argue that liposuction necessarily makes you gain fat in other areas. But if you look at that study, it was a small study, but also it was ridiculous. They kind of looked at a person had their lower abdomen done, and then they evaluated a year later and had more fat in the upper abdomen. Again, that's the whole thing about you're going to shift. But that's not an argument for liposuction for lipedema or non, causing it to go to other areas in a bad way.
I would say it happens in about 1/3 of the patients, but there was never a complaint about this.
Very accurate.
I have a lot of patients who need a knee replacement, and their surgeon won't do the knee replacement because they're too fat. If given the choice, do you do the knee surgery before or after liposuction? Who wants to take it?
I would do the liposuction before. So it allows the patient to walk correctly, not in the X way. It's easier, and it's easier for the surgeon.
Yeah, I would agree with that. I think from a wound healing perspective too, the orthopedic surgeon would feel a lot better about having skin and soft tissue over that prosthesis that is less robust, we'll say, and has a much higher potential for healing without complication.
I think the liposuction before, but you know, I've had some orthopedic surgeons actually write and insist that liposuction is covered and done first before they're going to go ahead with orthopedic surgery. So I think that definitely helps to support the case of liposuction hopefully being covered.
So in many cases, it's not a question what is done first, because the orthopedic surgeon refused to do the operation with having such a fatty layer over the knee. So they fear an infection, so they are not just offering the knee replacement. On the other hand, if you do a decent liposuction, you might get rid of the malalignment, and they improve immediately after the procedure. Maybe there is the knee replacement can be delayed for a couple of years. So anyway, so even the orthopedic surgeon would not reject the patient. I would always recommend doing the liposuction prior to the knee replacement.
So I will, I'll just, for your question back there about insurance, you know, insurance is a tricky thing, and unfortunately it doesn't always seem that they have the patient's best interest at heart, or I guess in many cases it doesn't seem that way. I think the big thing for insurance coverage, particularly for this, are that you have to prove to them that there's medical necessity for some functional reason. So you have to have documentation of functional issues, whether it's you know, I'm 40 years old and I have horrible arthritis and I need bilateral knee replacements. That's a bit unusual or out of the norm. Daily chronic pain, being on pain medications, documentation from your primary care physicians about coming in for pain-related issues, or back pain with regard to some of the lipedema that causes such a, you know, an angle or acute angle in the lumbar spine. Some sort of functional issue, immobility, those sorts of things are critical. Most insurance companies actually require you to have failed some form of conservative therapy. That's for a lot of surgeries in general, and their consideration of failed conservative therapy is MLD, compression garments, and the like. And so having documentation from therapists that show that your leg volume hasn't changed much is actually beneficial to you. Now, all the surgeons up here would tell you that we expect that your leg volume won't change much for those things because it's not going to do that. So for us, it's not considered a failure, but to the insurance company, it's considered a failure. And then I think probably the third thing, which maybe is most important, is to actually have a face-to-face consultation with the surgeon in their office, not an email chain or a Skype visit or something like that. You have to really have a face-to-face consultation that can go along with your note, so that exam is, yes, I'm the one that touched that patient, I'm the one that examined that patient, and these are my findings, and then with all the supported documentation. Unfortunately, you're still only going to get about 65%, at least at present, but it's better than zero. But it takes a lot of work because a lot of the insurance folks are going to want several weeks of that conservative therapy. So if you want surgery tomorrow, you're not going to get insurance to cover it in 24 hours. They're going to want you to do MLD and compression for maybe 3 months, depending on your insurance. It may be 6 weeks, 3 months. It could be longer than that, 6 months. So it's a process, and you have to understand that and work with the surgeon and the team and really get all of those ducks in a row before you start submitting to insurance so that you've really proven that there's a problem.
Any other comments on insurance? Besides it's difficult?
So there's a group of doctors, Stefan is one of them, they advise the government and the health insurance that we should cover this. The result cannot be seen now. So it's the end of 2017, we will have a decision from the government and from the insurance companies if they will cover the liposuction as a treatment for lipedema.
I also ask most patients to write a summary of what they've had happen during their life, and even to show some photographs of what they looked like as a child and what they did when they were teenagers and couldn't wear shorts, and life has been hard. Some patients have made this work. Another thing that works sometimes is to get an attorney involved. I've had 4 or 5 people try that, and 4 of them work that I can recall. So attorneys are good.
Yeah, I agree with everything that's said. It's still a challenging thing in the U.S. and it's nice to, I guess, hear it's the same thing in Germany too. But I think most of you know this. The more you really help to do your part to build a case, the more you increase your chances. And Pam Terry over there in the blue has, she came to you with a binder like this of seeing many different specialists. And I think when you've got, what you can't do is just go to the surgeon, expect to book the surgery the next week, a month later, expect it to get covered. The more you see people that recommend liposuction being done, whether it's an orthopedist, an internal medicine doctor, the more you have that done and documented before, the better your chances are.
Part of the problem with it is finding specialists who have any idea what lipedema is.
Karen, what do you think?
So in the TREAT program, we're going to change that. So our goal in the TREAT program is to create educational materials, and we want to roll it out initially to local primary care providers where I am, and then roll it out across the U.S. and beyond. So we want to change that for sure. I don't want to be the only one. Well, thank you so much for all of your time and input. I think it was really helpful.